Hello, welcome to another COVID-19 Law and Policy Briefing produced by Public Health Law Watch, a George Consortium initiative housed at Northeastern University School of Law. Thank you to our co-sponsors, the Center for Public Health Law Research at Temple University, the Network for Public Health Law, and Change Lab Solutions. We are here to provide expert legal analysis during the COVID-19 pandemic and hopefully to answer some of your questions. For more information on the legal response to COVID-19, please check out our report, Assessing Legal Responses to COVID-19 at www.covid19policyplaybook.org. Please use the hashtag COVID Law Briefing for any questions or comments in response to the briefing. I am Ruqaiijah Yearby, a professor of law and member of the Center for Health Law Studies at St. Louis University School of Law, as well as the executive director and co-founder for the Institute for Healing Justice and Equity at St. Louis University. Joining me today are Dr. Evan Anderson, who teaches health policy at University of Pennsylvania School of Nursing and Medicine, while his primary institutional home at Penn is the Center for Public Health Initiatives. And Dr. Michael Sinha is a research fellow at Harvard MIT Center for Regulatory Science, Harvard Medical School, and visiting scholar at the Center for Health Policy and Law at Northeastern University School of Law. Today, to get started, I'm going to begin by asking Dr. Anderson, should a Biden administration simply nationalize one or more PPE industries to address the shortages?
Oh, thank you so much for that question, and thank you to the organizers of this talk, and thanks for my interlocutors here. So that's a great question. I think that's a question that's on many people's minds, and it's been a question we've talked about a lot in the last 7 or 8 months. And I think the answer that I would give is that probably not. It's the Defense Production Act is an important tool, but it seems pretty clear to me that it's not easy to necessarily just force industry to produce more. These days, production is a lot more complex, and supply chains are a lot more complex than they were in World War II. I think the right use of the Defense Production Act, and it's something that's been terribly missing during the Trump administration, has been the use of purchase guarantees. So basically, the federal government committing to buying a lot of different PPE. And in that way, it removes the risk for producers, so that producers know that they can invest in the capital to make more masks, to make more gowns, and that they won't be exposed to huge losses if 3 or 4 months from now, once they've actually scaled up to capacity. If we're no longer in this moment of great need, that can be an enormous financial strain on companies. That's something we've seen in the recent history. So during the swine flu crisis in 2009, one company in particular invested a lot in capital investments, and it pushed that company to the brink of bankruptcy after, because once they were scaled up, there was no longer demand. So, I think purchase guarantees, purchase commitments is one really important tool. And then just coordination. So invoking the DPA so that the federal government plays an overarching coordinating role in the crisis is essential. But sort of forcing companies is probably not likely to be as successful. So the DPA has an important role to play. Nationalizing industries, I would argue, is probably not the most important use of the authorities.
Now turning to you, Dr. Sinha, hospitals are filling up. We will reach a crisis soon. So what will winter bring in terms of PPEs and hospital care?
Yeah, there's a number of things to think about in terms of hospital care. We're already at a point where hospitals are filling up in large cities, in rural areas. Some states are finding that if they need to try to transfer their patients to other hospitals in the region, those beds are also full. We're already at a crisis. And so I would frame it in two different ways. I would think about first the resources like PPE. These are commodities that can be purchased, that can be acquired. There certainly is a shortage. There are certainly ways that we probably could have increased production much earlier, talking 7-8 months ago. But I think the real crisis right now is the crisis of personnel. So we're actually seeing a shortage of nurses, physicians that are able to take care of COVID-19 patients. You're seeing radiologists, pediatricians being put on the front lines treating adult patients with COVID-19, some of whom have not been in that type of setting in years. A lot of people, especially on Twitter, talking about, that they're ready to quit. They're at their wits' end. This is too much for them. So I think what we need right now is to realize that it's not just about the number of beds and the number of ventilators, but it's about supporting the personnel that are required to operate that equipment, to visit that bedside, to take care of those patients. And we're really at a breaking point right now. I think the one thing that's missing from President-elect Biden's COVID-19 task force is mental health. I think that's something that we have to think about when we think about not only the mental health of patients and families, because obviously that is so important. You're seeing loved ones being intubated, saying goodbye via Zoom or via FaceTime. That's a complete tragedy, but you're also seeing that same emotional stress and breakdown among first responders, among clinicians on the front lines.
And just to follow up, you mentioned that what is missing from Biden's team is a focus on mental health. So what do we need to do to address this issue to support these healthcare providers?
Yeah, so I think we do have a lot of physicians who are not trained as critical care physicians. They're not trained as hospitalists, cardiologists, those that are traditionally on the front lines. And I think it's important to realize that a psychiatrist may be better suited to do something else than suit up and go room to room treating COVID-19 patients. That we can mobilize and gain, really get a whole system going where it's not just we have to go bed to bed, we have to do the following things, but it's what do we do when this aspect of our system starts to break down?
Mm-hmm. Coming back to you, Evan, let's talk about the supply chain and regulation and burn rate for N95s. They're a lot different than for gowns and ventilators or syringes. Do different experiences in addressing shortages of different products yield any insights into how we should think about the potential value and limits of federal policy levers?
It's a great question. So one of the many challenges with this crisis is that we've experienced shortages in lots of different products, and those products are manufactured and distributed, and regulated, and used in very different ways. So it sort of runs against this idea that the DPA can be wielded bluntly. It's really a scalpel that needs to be used as a way to coordinate not just sort of production and distribution, but also expertise. And we've had a number of false starts where we've made huge investments. Ventilators would be one and this has been covered quite a bit in the press, where we spent hundreds of millions of dollars for ventilators, which didn't have the features that were actually really important for them to have to be effective right away. And, doubly problematic maybe, they weren't built in a way where we haven't needed as much ventilators as we expected, but that would be okay if they just went into the strategic national stockpile. but these don't have a long shelf life. So, part of the coordination problem has also been marshaling expertise at the point of procurement, and that's something we can do a lot better. I also just want to stick in another point here, though, to this idea about the PPE. We're at a moment right now where, I think the Biden administration has indicated it's really going to aggressively try to support schools in reopening, which I think is a great idea. This will intensify shortages of PPE. We're going to need more masks to support teachers, and that's something we need to keep in mind as really important. And some of those, I think, some of the same mental health concerns and equity concerns, they're present and very acute in school settings as well.
Right. And just as you mentioned, when we think about the need for additional PPE, we haven't even given out enough in particular areas where people are being infected, right, in nursing homes and meat and poultry processing plants. I want to turn back to you, Michael, to talk about, as we shift the discourse between sort of hospitals and treatment to focus more on vaccines, right? We have to overcome this hesitancy for vaccines. Can you talk a little bit more about that, particularly as you mentioned in some of your work about the dual pandemics of sort of flu, COVID-19? How do you overcome people's hesitancy in getting vaccinated?
Yeah, I think that's a great question. I've thought about this quite a bit. I'm not sure that this dual pandemic of flu and COVID-19 is really going to pan out in the United States. We actually saw in Australia that there was a fairly significant decrease in incidence of flu during their winter. And I think part of that is because masking, social distancing, a lot of these things that we're doing to try to mitigate spread of COVID-19 also works for the flu. Now, in terms of getting vaccinated, I mean, I live in Boston. Hospitals are requiring vaccination, so my job requires me to get the flu vaccine, and if I don't, I'm terminated. So I received my flu vaccine. I'm likely to be one of the first few in line for the COVID-19 vaccine when it's ready. But I do worry about rural communities where they're not focusing on some of these mitigation strategies. They may be more reluctant to receive vaccines. Perhaps there isn't that herd immunity from flu vaccines that you might see in Boston. And you're talking about an additional vaccine. So I do think, I tend to live in this urban bubble in Boston, and it's hard to really look outside of that to see what's happening in rural areas. But I've studied in rural areas. I've trained in rural areas. I know what those communities go through on a regular basis, and I recognize the limitations of that infrastructure. And so I am certainly concerned about a double pandemic happening in states like North Dakota, South Dakota, Wyoming, where the infrastructure is not nearly as great, and the reluctance to vaccinate is certainly higher.
And just to follow up, as Professor Lindsay Wiley has said on multiple occasions, the term lockdown is problematic. It's not an on and off switch, it's more of a dial. So what kind of public health messaging do we need to be able to get buy-in from some of these skeptics?
Yeah, absolutely. I think I 100% agree with Professor Wiley's statement there. It's not an on-off switch. It really is a dial. And I think of the dial as going from 0 to 100, 100 being normal daily life, pre-pandemic, no worries, and then 0 being, essentially a ghost town, nobody on the streets. So in April, I think, especially in Boston, but in a number of other cities, New York City, Seattle, you saw people dialing down to maybe 25 or 20. There was a pretty substantial restriction in flow. But we're now at a point where the virus is far more widespread than it was in April. And I think in many places, we're still at a 50, 60, 70. And I think you could see that in the traffic for Thanksgiving. There were reports from the Transportation Authority that, traffic was down by maybe 20, 30%, but there was still a significant amount of traffic. There were reports of a number of large family gatherings. So I think that's something to be concerned about. In terms of selling, the idea that we need a lockdown, it worked in France. So severe restriction on movement and closing down major economic drivers or major businesses. We saw essentially uncontrolled spread, a huge spike in cases in France, just precipitously drop, essentially overnight. And that's because these measures really do work, but they work as long as you have buy-in from everybody. And so my concern is that with a 50-state approach to a pandemic and governors in certain states that are reluctant to impose certain restrictions, I mean, even in Massachusetts, the schools have been closed since the beginning of the year in many cases. Some have done a hybrid model, some have been entirely closed. Restaurants and bars are still open. Indoor dining is still open in Massachusetts. So I think it's a matter of framing the issue differently. It's not that we're locking down restaurants. It's not that we're locking down bars. It's that we're restricting, we're doing more social distancing. We're limiting congregation of people.
And just to follow up on that, thinking for you, Evan, when we think about coming out of this pandemic, what are the things that we need to do to ensure that we have a better response, particularly in terms of PPE and mask?
Yeah, I mean, thank you for the question, and I think I'll take that even more broadly. We need to invest in public health, and we need to invest in the basic infrastructure of public health at the local and the state level. Ultimately, I think whether it's lockdowns or vaccine hesitancy, we can succeed in responding to those challenges with credible local champions. But there has to be an infrastructure in place, and there has to be a sort of a history locally of really delivering public health resources. And we've so disinvested from public health in the United States that there is understandable skepticism at the local level in many instances. So the most important issue is reinvesting in our public health infrastructure, but then also using this as an opportunity to reflect on healthcare delivery in the United States, because the crisis has demonstrated many of the problems in the delivery of healthcare. An overemphasis on efficiency, which has made us unable, inflexible, focus on profit-driven models. We've lost our resiliency and our ability to meet a challenge that puts us under any amount of strain. So I think back to fundamentals, investing in public health is the key to responding to all of these challenges.
And for you, Michael, what do you think about moving forward? You focused on particularly health professionals. What do we need to do after this crisis?
Yeah, so I would just like to point out that during this crisis, I think that the primary thing we need to build up state and local public health systems are federal funding. And that's because states are bound by budgets. They don't have the access to overspend on these resources. We passed the CARES Act several months ago. A lot of those funds, nearly a $500 billion in those funds, have not been spent, are likely to be put back into the general fund of the U.S. Treasury, meaning that they can't be touched by the next administration. Congress seems deadlocked. They're not likely to pass additional funding soon. I think that's a real problem. And I think funding, congressional funding signifies that the federal government is willing to support healthcare professionals. We need a sign from our government that says we support you. We support the work you're doing. You know, in New York City, the 7 p.m. Clapping outside on the balconies, you know, thanking a healthcare hero, that only goes so far, right? So it needs to be more in terms of showing and proving than just simply congratulatory or you know, these types of measures where it's simply saying thank you without acting upon that by doing more. I think that's what's needed at this point.
Well, thank you. I so appreciate your comments and thoughtful discussion on these topics. Any last words? Evan?
Yeah, sure. You know, there's been so much avoidable harm that I'm hopeful that we can do a much better job in the coming months. You know, I think a vaccine isn't going to cure all of our problems, so we're going to need to continue to layer different prevention modalities on top of each other. And doing that means also coming to terms with fatigue and being honest and continuing to improve the way we communicate. And thinking about how the burdens also of some of these modalities are distributed. But I'm hopeful that we can certainly do better.
Michael?
Yeah, so I'm certainly hopeful, although I'm skeptical that we're going to see federal government intervention from now until the inauguration. And so the real concern for me is trying to sort out what we need to be doing as individuals. So staying home, flattening the curve. I mean, that terminology was used in March and April and it's been lost. The curve is not flat. The curve is spiking substantially. We need to get back to that mentality that we as individuals have a role in flattening the curve. And then the science of vaccine production, distribution, I hope will come in due time. But again, we absolutely cannot vaccinate and expect this problem to just go away. We have to do more than that. We have to stay vigilant. We have to continue these measures even beyond the date that you and I, or the three of us, or communities are vaccinated. There's more to it than that.
Well, thank you. Thank you to my guests and to all of you for listening today. We will be broadcasting here on Twitter every Tuesday and Thursday at noon. Just go to @PH Law Watch or search /COVID Law Briefing. Recordings are available on the Public Health Law Watch website, and the shows are archived by the week in Health Law Podcasts at www.twihl.com. The COVID-19 and policy briefings are produced by Faith Kalig, Summer Brown, and Liz Voiles. We'll see you next time. Please stay safe. Thank you.